Hello and welcome to my poster. My name is Joyce Lee and I'm currently a second-year medical student here at MCW. With the support of the Institute for Health and Equity, I conducted research with Dr. Fabrice Lee-Jotterand as my mentor. This past summer, I designed and carried out a systematic review to assess the state of mental health care across racial and ethnic minorities in the United States, as well as identify its impacts and solutions using the tools provided by the field of mental health ethics. Before I started medical school, I completed my thesis for my bioethics master's that focused on mental health care among Asian Americans. I used bioethical principles to analyze the shortcomings that Asian Americans faced in regards to mental health and ways in which they may be addressed and overcome. In my research, I learned that all racial and ethnic minorities have reported using mental health services less often than non-Hispanic whites, and that they are often more severely ill and receive poor quality mental health care when they do seek it out. With this information, I wanted to further expand my previous research to include the other racial and ethnic minority groups residing in the United States. My systematic review is poised to use mental health ethics, a field that connects bioethics, neuroethics, and psychiatric ethics, to identify the specific causes that led to worsened mental health care among minorities and to propose potential solutions to improve it. My systematic review adheres to the guidelines set forth by the Preferred Reporting Items for Systematic Reviews and Meta-Analysis, or PRISMA for short. I work with a medical librarian to cross-reference the Medline PubMed Health Disparities and Minority Health Search Strategy with additional mental health search terms. Papers were then included and excluded based on certain criteria using the online tool Rayan.ai. Data were then extracted, synthesized, and analyzed. Certain limitations like selection and confounding biases were also present, as I acted as the sole reviewer in the systematic review. These were the inclusion and exclusion criteria I utilized when I was screening through papers. Important inclusion criteria included published studies in English between 2010 and 2021 that specifically stated racial and ethnic minorities in the U.S. and had race or ethnicity considered as an independent variable or covariate in assessing an aspect of mental health care. The exclusion criteria here allowed me to filter out studies that may have introduced confounding variables that were not the focus of the systematic review. This flowchart describes the selection process of the final set of papers with data that are later extracted, synthesized, and analyzed. As you may see on the right-hand side, the distribution of papers among different racial and ethnic groups varies, with very few publications focusing on American Indians or Alaskan Natives and on Native Hawaiians or other Pacific Islanders. Preliminary results of the systematic review included findings on American Indians or Alaskan Natives racial group, abbreviated as AIAN. Of the 4 papers in this category, AIANs were found to reveal largely negative attitude towards mental health as a result of unfavorable previous experiences with mental health services. There was also a difference in preference in mental health treatment between younger and older AIANs. There was also a high prevalence of substance use disorders and adverse childhood events among AIANs than among non-natives, both of which led to increased mental health problems. As I applied the 4 bioethical principles of autonomy, beneficence, non-maleficence, and justice, I was able to identify applicable solutions that mental health care providers may adopt to improve the quality of care among AIANs. To maximize the autonomy of AIANs, it is critical for providers to acknowledge their historical loss of autonomy from collective generational and lifespan traumas that may have led to their mistrust of Western civilization and medicine. Additionally, providers should attribute as much autonomy as possible to AIANs in assessing treatment and care. Beneficence and non-maleficence are also addressed by acquiring complete and detailed patient histories, by incorporating culturally relevant components in mental health assessments, services, and interventions, and by improving non-cultural factors such as minimizing wait times, medication dissatisfaction, and counseling unavailability. Finally, justice is considered by recognizing increased numbers of uninsured or underinsured AIANs, which may have limited their access to mental health services. Ways to increase access may include direct community interventions and the establishment of free clinics among AIANs. As I've only had the chance to assess the state of mental health care among AIANs and provide solutions for them this past summer, the future direction of this project will be to continue the research on the other racial minority groups. This project would not have been possible without the opportunity provided to me by the grant I received from the Institute for Health and Equity as part of the SAMS and MSSRP. I also want to thank Dr. Lee-Jotterand, who helped me throughout this project with his expertise. Lastly, I want to thank Professor Kim Hopper of Columbia University for advising me on my master's thesis that provided the groundworks for this research. For questions or comments, you may reach me at my email. Thank you so much for listening.